Welcome to the Rad Onc Smart Review GYN Cancer series.
Great to be here.
Today, we're kicking off our focus on cervical cancer. This is part 1.
Right. We're laying the groundwork, staging the essential workup, and then really digging into the evidence for early-stage disease.
Exactly. The goal is to build that solid foundation you need when you first encounter a new diagnosis, hitting those high-yield points for boards, and, more importantly, for taking care of patients.
And to make it practical, let's frame it around a typical case.
Good idea. Let's talk about Miss Garcia.
Okay.
She's a 42-year-old woman, comes in with really the classic symptom, postcoital bleeding.
Very common presentation.
On exam, there's a firm 3-centimeter mass on her cervix. Biopsy comes back invasive squamous cell carcinoma.
Okay. And otherwise healthy.
Otherwise healthy, yes. Important detail.
Absolutely. So right off the bat, this case brings up the two big questions we need to tackle.
Right. First, after we do the full workup, what's her official FIGO stage? That dictates everything.
And second, based on her specific situation, that 3-centimeter tumor, what's the best primary treatment approach? Are we thinking radical surgery, or should we be heading straight for definitive chemoradiation?
Those are the core questions. To answer them, we really need to start from the beginning.
Agreed. Let's talk epidemiology, pathophysiology, how this cancer actually spreads.
Okay, so cervical cancer. In the U.S., it's the third most common GYN malignancy.
Yeah, behind endometrial and ovarian. But you have to remember, globally, it's a completely different picture.
A huge public health issue, especially in lower and middle-income countries without widespread screening or vaccination.
Precisely. And the cause, well, it's remarkably clear compared to many other cancers.
It's HPV. Persistent infection with high-risk human papillomavirus, almost all cases.
Yeah, virtually 100%. And you absolutely need to know the key players.
HPV types 16 and 18.
Those are the heavy hitters, responsible for about 70% of cases worldwide.
But you can't forget the others, 31, 33, 45, etc. They make up the rest.
Right. Knowing the etiology is key. So what increases the risk of getting HPV, or, maybe more importantly, having it persist?
Well, factors that increase exposure, like early onset of sexual activity, multiple partners. That makes sense.
And crucially, anything that weakens the immune system's ability to clear the virus?
Immunosuppression, which is why HIV testing is really mandatory in the workup.
Absolutely. But there's another factor, a non-infectious one, that's a really important cofactor, especially for squamous cell carcinoma.
Soaking.
Exactly, smoking. It often gets a bit sidelined, but it's a significant independent promoter.
How does that work? Do we know the mechanism?
The thinking is that carcinogenic toxins from smoke concentrate in the cervical mucus. And this likely damages the local immune cells or the epithelium itself, making it harder for the body to clear that HPV infection.
So counseling on smoking cessation is actually part of managing the cancer risk itself.
Definitely. If Miss Garcia is a smoker, that's a critical conversation to have.
Okay. And this ties into the pathology, the molecular basis. Understanding this isn't just academic, it underpins screening and prevention.
Right. We mainly see two histologies in practice. Squamous cell carcinoma is the most common, maybe 75–80%.
Typically arising right at the squamocolumnar junction, the transformation zone.
Exactly. And then there's adenocarcinoma, making up the other 20–25%.
Sometimes thought to be a bit more aggressive, maybe harder to pick up on pap smears.
That's been a concern, yeah. Though modern HPV testing helps mitigate that. But regardless of histology, the molecular driver is the same. This is a must-know board pearl.
The HPV oncoproteins, E6 and E7.
These are the functional proteins expressed by the high-risk HPV types. Once integrated into the host genome, they're the bad guys.
It's like a two-hit combo on cell cycle control.
Precisely. E6 targets and degrades the tumor suppressor protein P53.
The guardian of the genome. Taking that out removes a major brake on abnormal cell growth and prevents apoptosis, programmed cell death.
Right, and E7 goes after another key tumor suppressor, the retinoblastoma protein, RB.
What does inactivating RB do?
RB normally holds on to a transcription factor called E2F, keeping it in check. When E7 binds and inactivates RB, E2F is released.
And E2F then turns on genes needed for DNA replication and cell division.
Exactly. It pushes the cell cycle forward uncontrollably. So you knock out P53, you inactivate RB, boom, uncontrolled proliferation and malignant transformation.
It's a really elegant, albeit destructive mechanism. And like you said, knowing This is why we can screen so effectively.
Yeah, the whole screening framework relies on detecting HPV or the cellular changes it causes. We follow the ACS 2020 and USPSTF guidelines here in the US.
Historically, it was all about the pap smear, looking at cell morphology.
Right, cytology. But the shift now is towards primary HPV testing.
Preferred method: test for high-risk HPV DNA every 5 years, starting typically at age 25.
It's a better predictor of long-term risk than cytology alone. Co-testing doing both HPV and cytology is still an option, as is cytology alone in some settings.
But the big change isn't just the test, it's how we manage the results, right?
Yeah, absolutely. We've moved away from fixed rules based just on the result. Now, management follows the ASCCP 2019 risk-based algorithms.
Meaning you integrate the current result, the specific HPV type if known, and the patient's past history to calculate their individual risk of having or developing high-grade precancer or cancer.
Exactly. It's a much more personalized, dynamic approach. It helps avoid unnecessary procedures for low-risk findings while making sure we appropriately manage the high-risk ones. A major step forward.
Okay, great foundation. Before we jump into staging Mrs. Garcia, we need to talk about how cervical cancer spreads, particularly nodal spread.
Critical, because nodal involvement fundamentally changes the stage and treatment. Locally, the spread is usually direct, contiguous.
Into the perimetry of the tissues right next to the cervix or down the vaginal wall, or maybe into the bladder or rectum if it's really advanced.
But metastatic spread is primarily lymphatic, heading first to the pelvic lymph nodes.
Obturators, internal iliacs, external iliacs, common iliacs.
Right. And if it gets past the pelvis, the next stop is typically the para-aortic nodes along the aorta and vena cava.
So how do we estimate that nodal risk clinically, maybe before we even have the PT scan back?
There's a classic heuristic, a memory aid for residents, that's still pretty useful. The rule of 15s.
Yeah, okay. The rule of 15s, how does that work?
It gives you a rough estimate of the pathologic risk of pelvic lymph node involvement based on the clinical stage.
Okay.
For stage 1 disease, think approximately 15% risk of pelvic nodes.
15% for stage 1.
For stage 2 disease, it roughly doubles about 30% risk.
Stage 2, 30%.
And for stage 3 disease, it goes up again around 45% risk.
Stage 3, 45%. So 15, 30, 45.
Exactly. Now, why bother with this in the era of PTCT? Because remember, staging starts clinically, and these numbers remind you of the underlying biological risk. A small tumor can still have positive nodes.
It sets expectations and guides the workup.
Precisely. And there's a corollary. The risk of periaortic node involvement is generally about half the pelvic risk for that stage.
Okay, so if pelvic risk is 30%, periaortic might be around 15%.
Roughly, yeah. So for Miss Garcia, who we suspect might be stage 1B2 based on the 3-centimeter tumor.
Her pelvic node risk is already in that 15–20% ballpark, maybe higher given the size.
Exactly. Which
Yeah.
immediately tells you why a PTCT scan is going to be essential for her staging.
Makes sense. That brings us perfectly to the workup and the current staging system.
Okay, the workup needs to be meticulous. Treatment hinges entirely on getting the stage right. Let's tick through the checklist for Miss Garcia.
Starts with a physical exam. Speculum exam to visualize the tumor. Bimanual exam to feel the uterus, adnexa.
And crucially, the rectovaginal exam.
Cannot emphasize that enough. It's not optional.
Absolutely not. It's often the best way to clinically assess for parametrial involvement. You're feeling for that characteristic woody, firm induration extending out from the cervix towards the pelvic sidewall.
Finding that immediately changes the stage from potentially operable 1B or 2A to inoperable 2B.
Correct. Then, of course, the biopsy-confirmed invasive squamous cell. We need tissue.
Supportive labs next. Baseline blood counts, chemistries, liver function tests.
Mandatory pregnancy test for a premenopausal woman like Mrs. Garcia.
And as we discussed, strongly consider HIV testing given the link with HPV persistence and immunosuppression.
Right. And one more really important point for a 42-year-old woman facing potentially curative treatment.
Fertility.
Yes, early discussion about fertility preservation if she hasn't completed childbearing. It can significantly impact surgical options if surgery is on the table.
Okay, exams, labs, counseling. Now, imaging. This is where modern staging really happens. How do we approach it?
We think about it in two parts, local staging and then nodal distance staging.
For local staging, defining the primary tumor and its relationship to adjacent structures.
MRI of the pelvis with contrast is the gold standard, highly preferred over CT.
Why is MRI so much better there?
It's all about soft tissue contrast resolution. MRI lets you see the layers within the cervix and the surrounding tissues much more clearly than CT.
Which leads us to a really important clinical pearl for reading these MRIs.
Yes. You need to look specifically at the T2 weighted images.
On T2, the cervical cancer itself usually shows up as intermediate to high signal intensity, kind of bright.
Right. But the key is the normal cervical stroma surrounding it. Healthy stroma appears as a distinct, low-signal, dark ring on T2.
The high point tense stromal ring.
Exactly. If you can clearly see that dark stromal ring fully intact all the way around the tumor.
That argues strongly against perimetral invasion. The tumor is contained within the cervix proper.
Correct. But if that dark ring is breached, if the brighter tumor signal extends through it into the perimetrial fat, that's your radiological evidence of perimetrial invasion, stage 2B.
You really have to be able to look for that yourself on the MRI. It's a critical finding that dictates management surgery versus radiation.
Absolutely. Okay, that's local staging with MRI. What about nodal and distant staging?
For that, PT-CT is the recommended tool.
Is it needed for everyone, like stage 1A?
Not strictly required for the very earliest microscopic stages, but for any tumor stage 1B2 or larger, like Mrs. Garcia's 3-centimeter tumor, or basically any time you're planning definitive chemoradiation, PT-CT is mandatory.
Why is P so crucial now?
Because of the FIGO 2018 staging update. Finding even a single positive lymph node on imaging now upstages the patient significantly, usually to stage 3C.
Ah, right. PT is much more sensitive than CT alone for detecting those small metastatic nodes, especially in the pelvis and periaortic regions.
Exactly. It gives you the best survey of the entire nodal basin and rules out distant mets, ensuring you target the right areas if radiation is needed.
Okay, so MRI for local detail, PT-CT for nodes and distance. That sets us up perfectly for the FIGO 2018 staging system itself.
This was a major shift, formally bringing imaging and even pathology findings into the official stage, moving beyond just the clinical exam. Let's walk through it.
All right, stage 1. Disease is strictly confined to the cervix.
Within stage 1, we have 1A, which is microscopic disease only, found on a cone biopsy or hysterectomy specimen.
Right. 1A1 is invasion less than or equal to 5 millimeters deep.
Slight correction there. Based on the latest FIGO, 1A1 is actually less than 3 millimeter depth of invasion.
Ah, right. Thank you. 1A1 is 3 millimeter depths, and 1A2 is depth from 3 millimeter up to, but not including 5 millimeter.
Correct. Then we get to stage 1B, which is clinically visible or microscopic invasion equal to or greater than 5 millimeters deep. Here, the staging is based purely on the largest tumor dimension.
Okay.
Stage 1B1. Tumor size is 5 millimeter depth or greater, but the overall largest dimension is less than 2 centimeters.
1B1.
2 centimeters, stage 1B2. Tumor is 2 centimeters or larger, but less than 4 centimeters.
1B2. 2 centimeters to 4 centimeter. This is where Mrs. Garcia fits, with her 3-centimeter tumor, assuming her scans are negative.
Exactly. And stage 1B3. Tumor is 4 centimeters or larger.
1B3, 4 centimeters. These are the bigger ones. Okay,
yeah.
that's stage 1, confined to the cervix.
Now, stage 2. The tumor invades beyond the uterus, but hasn't gone to the pelvic sidewall or the lower third of the vagina. Stage 2A involves the upper 2/3 of the vagina, but without perimetral invasion.
So, vaginal extension, but the perimetry are clear on exam and MRI.
Right. Stage 2B is defined by perimetral invasion. That's where the positive rectovaginal exam or the MRI finding of stromal ring breach comes in.
Got it. 2A vaginal, 2B perimetral.
When stage 3 represents more extensive local spread.
Okay.
Stage 3A, tumor involves the lower third of the vagina.
Lower third vagina equals 3A.
Stage 3B has 2 possible criteria. Either tumor extends all the way to the pelvic sidewall, making it feel fixed on exam,
Okay, fix a sidewall.
or the tumor causes hydronephrosis blockage of a ureter leading to kidney swelling, or a non-functioning kidney presumed due to the tumor.
Right. So sidewall fixation or hydronephrosis non-functioning kidney automatically makes it stage 3B, regardless of primary tumor size or vaginal extension.
Correct. And now for the biggest change in FIGO 2018, the board pearl.
Stage 3C.
Stage 3C, defined entirely by lymph node metastasis irrespective of the T stage, the primary tumor size extension.
This was huge. Before 2018, you could have a small 1B1 tumor with a positive pelvic node, and it was still technically stage 1D1, which didn't make sense prognostically.
Exactly. Now, any nodal metastasis automatically bumps it to stage 3C.
And it's subdivided based on location.
Stage 3C1, metastasis confirmed in pelvic lymph nodes only.
3C1 pelvic.
Stage 3C2, metastasis confirmed in periaortic lymph nodes with or without pelvic node involvement.
3C2 periaortic. And they added suffixes too, right?
Yes. Or if the node was identified radiographically, like on PET-CT or MRI, and P if it was confirmed pathologically after surgery. So you might see stage 3C1R or 3C1P.
Okay, that allows for more precision. Good.
And finally, stage 4 is distant spread. 4A is direct invasion into the bladder or rectal mucosa. You need to see it on cystoscopy or sigmoidoscopy.
Okay, bladder rectal mucosa.
And 4B is any distant metastasis, lung, liver, bone, distant nose like supraclavicular.
All right. That's a comprehensive staging system, much more detailed with the integration of imaging.
So let's bring it back to Ms. Garcia. Clinically visible 3-centimeter tumor confined to the cervix on initial exam. Assuming her MRI confirms no parametrial invasion and her PET-CT is negative for nodal or distant mets.
She is stage 1B2.
Exactly, which puts her right in that classic decision point, surgery or definitive radiation. Before we tackle that debate using the big trials, let's quickly touch on the management for the very earliest stage, stage 1A, especially regarding fertility.
Good point. Because treatment there can be much less invasive.
For stage 1A1, that tiny invasion less than 3 millimeter deep if there's no lymphovascular space invasion, LVSI, seen on the cone biopsy.
Then the risk of nodal spread is incredibly low, less than 1%.
So a simple hysterectomy can be curative, or if fertility is desired and margins on the cone were negative, even just the cone biopsy itself might be sufficient treatment. Observation.
Right, but the game changes if LVSI is present, even in 1A1.
Or if it's stage 1A2 invasion between 3 and 5 millimeter deep.
In those cases, the risk of pelvic node metastasis climbs to maybe 5–8%. It's still low, but it's significant enough that you must evaluate the lymph nodes.
Okay, so nodal evaluation becomes mandatory for 1A1 with LVSI or for any 1A2. How do we do that if the patient wants to preserve fertility?
The standard approach now is a fertility-sparing local procedure, either another cone biopsy to ensure clear margins, or a simple trachelectomy, removing just the cervix, combined with pelvic sentinel lymph node mapping.
Ah, SLN mapping, not a full dissection.
Exactly. SLN mapping is crucial here. You inject a tracer dye, like ICG or blue dye, around the cervix to identify the first draining sentinel nodes in the pelvis.
You remove just those few nodes.
Right. If they're negative on pathology, the odds of other nodes being positive are extremely low, and you've avoided the morbidity of a full pelvic lymph node dissection like lymphedema.
Makes sense. Minimal surgery for maximal information with fertility preservation. What if the sentinel node is positive or you can't identify one?
Then, unfortunately, a full pelvic lymph node dissection is usually necessary, and fertility preservation often becomes much more complex or impossible, potentially requiring definitive chemoradiation.
Okay. Important nuances for the earliest stages. Now let's pivot back to Ms. Garcia's stage 1B2 tumor. Surgery versus radiation. We need to talk evidence. Landmark trials.
Absolutely. And the first big one everyone needs to know is the Landoni trial, published way back in 1997.
This was foundational. For years, radical hysterectomy was kind of the default for early-stage cervical cancer, stages 1B to 2A.
Right. Landoni was the first large, randomized trial to directly compare radical hysterectomy with lymph node dissection versus definitive radiation therapy.
What was the bottom line?
Oncologic equivalence. In terms of 5-year overall survival, the results were virtually identical. 83% for surgery versus 83% for radiation.
So radiation was proven to be just as effective at curing the cancer.
Exactly. That was a huge finding. But here's the critical part, the major clinical decision point that came out of Landoni.
The morbidity.
Yes, the rate of severe treatment-related complications was significantly higher in the surgery arm. 28% experienced severe morbidity with surgery compared to only 12% with primary radiation.
Wow, more than double the severe side effects with surgery, even though survival was the same. Why?
The driver was adjuvant therapy. A staggering 64%, almost 2/3 of the patients who had surgery first, ended up needing postoperative radiation therapy anyway.
Because pathology found high-risk features after the hysterectomy, like positive nodes, positive margins, deep stromal invasion, parametrial involvement.
Exactly, those SEDLIS criteria or other high-risk factors. And when you give radiation after radical surgery, especially including brachytherapy, that's triple modality treatment.
Surgery, then external beam, then brachytherapy.
The toxicity skyrockets. The combined insult to the bowel, bladder, vagina leads to much higher rates of long-term severe dysfunction compared to giving definitive chemoradiation up front without the surgery.
So the takeaway from Landoni wasn't just that radiation works, but that if you anticipate a high likelihood of needing adjuvant radiation based on the initial tumor characteristics,
You should strongly consider skipping the surgery and going straight to definitive chemoradiation to spare the patient that significantly higher risk of severe long-term morbidity from triple modality therapy.
Makes perfect sense. Landoni established radiation as an equal and often less morbid primary option. Fast forward 2 decades. Surgery itself comes under scrutiny with another landmark trial.
Right. The LACC trial, published in 2018, this one addressed a different question.
It wasn't surgery versus radiation. It was how to do the surgery.
Exactly. By the 2010s, minimally invasive surgery, laparoscopic or robotic-assisted radical hysterectomy was becoming really popular for early-stage cervical cancer, like 1B1, maybe some 1B2.
Surgeons liked it. Patients liked the idea of smaller incisions, faster recovery.
Seemed like a win-win. So the LACC trial was designed as a large international randomized study to prove that minimally invasive radical hysterectomy was non-inferior to the traditional open abdominal radical hysterectomy for these early stages.
They wanted to show it was just as good oncologically. What happened?
The results were stunning and, frankly, devastating for the MIS approach. The trial was stopped early by the Data Safety Monitoring Committee because of clear harm in the minimally invasive arm.
Harm? What kind of harm?
Significantly worse cancer outcomes. The 3-year disease-free survival rate was substantially lower, with minimally invasive surgery 91.2% versus 97.1% for open surgery.
That's a big difference, and nearly 6% absolute difference in recurrence at 3 years.
And even more concerning, overall survival was also trending worse in the minimally invasive group.
Wow. So the conclusion was unavoidable.
Absolutely. Open abdominal radical hysterectomy must be considered the standard of care when surgery is chosen for early-stage cervical cancer. Minimally invasive approaches for radical hysterectomy are simply not recommended due to these inferior oncologic outcomes, a major paradigm shift.
It really sent shockwaves through the GYN oncology world. Why? Why would MIS be worse here when it works well for, say, endometrial cancer?
That's the million-dollar question, and we still don't have a definitive answer, but there are strong hypotheses. One leading idea involves tumor handling and potential cell spillage.
Meaning?
With MIS, you often use a uterine manipulator inserted through the cervix and vagina to move the uterus around in the closed CO2-insufflated abdomen. There's concern that this manipulation, combined with the pneumoperitoneum pressure, might inadvertently dislodge tumor cells or push them into lymphatic channels or the peritoneal cavity more easily than the potentially gentler handling during an open procedure.
Or maybe disruption of tissue planes?
Possibly. The tumor-uterus interface might be handled differently. It highlights that cervical cancer might have unique biological properties, making it particularly sensitive to surgical technique and manipulation. The bottom line, though, is the data. Open is superior for radical hysterectomy.
Okay, Landoni and
Yeah.
LACC, 2 absolutely critical trials shaping our management. Let's apply them directly now.
All right, back to Miss Garcia. 42 years old, healthy, stage 1B2 squamous cell carcinoma, a 3-centimeter tumor confined to the cervix, negative scans. What do we recommend?
Landoni tells us surgery, radical hysterectomy, and definitive radiation offer equivalent survival, equivalent cure rates.
Right. So oncologically, both are valid options. The decision pivots to morbidity.
And Landoni's key finding was that morbidity skyrockets if you need adjuvant radiation after surgery.
Exactly. So the crucial question for Ms. Garcia is, what's her risk of needing adjuvant chemoradiation if she has surgery first?
Well, she has a 3-centimeter tumor, that's stage 1B2. What are the typical risk factors found after surgery for a tumor like that?
For a 1B2 tumor, the risk of finding positive pelvic nodes, deep stromal invasion, or microscopic parametrial involvement, things that would trigger adjuvant chemoradiation, is significant. It's certainly not low, maybe in the 20–40% range depending on specific features.
So there's a substantial chance, maybe 1 in 3 or 1 in 4, that if she has an open radical hysterectomy, she'll still need the full course of pelvic radiation and chemotherapy afterwards.
Correct. Putting her right into that high morbidity, triple modality category that Landoni warned us about.
Therefore, to optimize both cure and long-term quality of life.
For most patients with stage 1B2, and certainly for 1B3 tumors where the risk of needing adjuvant therapy is even higher, the preferred recommendation is generally to bypass surgery and proceed directly to definitive chemoradiation up front.
Avoid the surgery, avoid the risk of triple modality toxicity, achieve the same excellent cure rate with primary chemoradiation.
That's the standard rationale. Now, it's always a discussion with the patient, weighing individual factors, but based purely on the evidence for a typical 1B2. Definitive therapy is often favored.
Okay, so let's say we recommend definitive chemoradiation for Mrs. Garcia. What does that actually involve? Let's detail a regimen.
It's a highly standardized multi-component treatment. It starts with external beam radiation therapy, EBRT.
Using high-energy X-rays targeted from outside the body, where do we aim?
We treat the whole pelvis. That includes the cervix, the uterus, the parametria, the upper vagina, and crucially, the pelvic lymph node drainage basins, external iliacs, internal iliacs, obturators, presacral nodes.
What's the dose for the external beam portion?
Typically 45 gray delivered in 25 daily fractions over 5 weeks. Sometimes we might go up to 50.4 gray in 28 fractions, especially if lymph nodes were initially involved and cleared, or if there's a slower response.
And we use modern techniques like IMRT or VMAT.
Absolutely. Intensity modulated radiation therapy or volumetric modulated arc therapy allow us to shape the dose precisely, conforming it to the target volumes while minimizing dose to nearby organs at risk, like the small bowel, bladder, rectum, and bone marrow.
Okay, 5 weeks of pelvic EBRT. What else?
Concurrent chemotherapy. This is essential. The chemo acts as a radiosensitizer, making the cancer cells more vulnerable to being killed by the radiation.
It boosts the effect of the radiation locally.
Massively. Multiple randomized trials prove that adding concurrent cisplatin-based chemotherapy significantly improves local control and overall survival compared to radiation alone.
What's the standard chemo regimen?
Weekly cisplatin, given intravenously once a week during the 5 weeks of external beam radiation. The dose is usually 40 milligrams per meter squared.
Cisplatin 40 milligene 2 weekly by 5-6 cycles.
Correct. It intercalates into DNA, prevents repair of radiation-induced DNA damage. Very effective.
Okay, EBRT plus weekly cisplatin. Are we done?
Not even close. The most critical component for cure in locally advanced cervical cancer, the part that delivers the knockout blow to the primary tumor, is brachytherapy.
Internal radiation is mandatory, right?
Absolutely mandatory if the goal is cure. You cannot cure stage 1B2 or more advanced cervical cancer with 45-50 GJs of external beam alone. The dose isn't high enough to eradicate the gross tumor.
So how does brachytherapy work?
After the external beam portion shrinks the tumor, we insert applicators directly into the uterus and vagina, placing them right up against the residual tumor and cervix.
Like a tandem down the uterine canal and ovoids or ring in the vaginal fornices.
Exactly. Then we load radioactive sources into those applicators for a calculated amount of time. This allows us to deliver a very high, highly conformal radiation dose directly to the tumor target volume.
Well, the dose falls off very rapidly, just millimeters away.
Precisely. That rapid dose falloff is key. It lets us escalate the dose to the tumor to levels needed for ablation, often reaching a total biological equivalent dose of 80 to 85 gray, or even higher, while keeping the dose to the nearby bladder and rectum within tolerance limits.
And we use image guidance now, right? IGABT.
Yes, image-guided adaptive brachytherapy is the standard. We typically get an MRI or CT scan with the applicator in place before each brachytherapy fraction.
To see exactly where the tumor is relative to the applicator and the normal organs.
Right. We then contour the remaining high-risk clinical target volume, HRCTV, based on the imaging, and prescribe the brachytherapy dose to cover that volume adequately. We aim for a specific metric, the HRCTV D90.
D90 meaning the minimum dose received by at least 90% of that high-risk target volume.
Correct. And we want that D90 to be around 80 to 85 gray EQD2.
EQD2 equivalent dose in 2 gray fractions. A way to biologically standardize the dose from the high-dose rate brachytherapy pulses compared to the daily EBRT fractions.
Exactly. Achieving that target EQD2 is strongly correlated with local control. It's critical.
Okay, EBRT plus chemo, followed by brachytherapy boost. Anything else about timing?
Yes, another major board pearl. The overall treatment time. The entire course, from the first day of EBRT to the last fraction of brachytherapy, must be completed as quickly as reasonably possible, ideally within 8 weeks or 56 days.
Why is that so important?
Tumor cell repopulation. If the treatment course gets prolonged, any surviving cancer cells have more time to regrow between radiation fractions, which significantly reduces the chance of cure. Keeping the overall treatment time under 56 days is a key quality metric.
Got it. It's an intense treatment package. We absolutely need to counsel Ms. Garcia thoroughly on the side effects, the toxicities.
Definitely. We divide them into acute, during treatment, and late, long-term.
Acute effects.
Fatigue is almost universal. GI effects like diarrhea are very common. We manage proactively with diet, hydration, loperamide. GU symptoms like urinary frequency, urgency, maybe some burning, cystitis, skin reaction in the groin folds or perineum.
And side effects from the weekly cisplatin.
Primarily hematologic drops in white blood cells, platelets, sometimes red blood cells, requires weekly blood count monitoring. Nausea can occur, but is usually well managed with modern antiemetics. Some risk of kidney toxicity, so hydration is key.
Okay, those are generally manageable, temporary. What about the late effects, the ones that can linger?
Those are the ones that really impact long-term quality of life. Chronic changes in bowel function, urgency, frequency, occasional bleeding from radiation proctitis, chronic bladder changes, frequency, urgency, reduced capacity, sometimes hematuria.
Risk of pelvic insufficiency fractures.
Yes, particularly in the sacrum or pubic bones, especially in postmenopausal women. And lymphedema, swelling in the legs, if the pelvic nodes received significant dose, though less common with modern techniques than after full surgical dissection.
And one absolutely critical late effect we must discuss proactively with every patient receiving pelvic radiation for cervical cancer.
Vaginal stenosis.
Yes, the radiation causes inflammation and then scarring and fibrosis of the vaginal tissues. This leads to shortening and narrowing of the vagina.
Which can significantly impact sexual function, make intercourse difficult or painful, and even make future pelvic exams challenging.
So what's the essential counseling point here?
Proactive use of a vaginal dilator. Starting a few weeks after treatment finishes, patients need to use a dilator regularly, typically several times a week, to gently stretch the vaginal tissues and maintain patency and length.
It's not just about sexual function. It's about maintaining overall vaginal health and accessibility for follow-up. This needs to be discussed up front and reinforced.
Absolutely non-negotiable counseling point.
Okay, we've covered a lot of ground. The why with HPV, the where with staging, the how with treatment evidence and details. Let's crystallize some key takeaways and run through some board-style scenarios.
Good plan. Let's hit those clinical pearls again for reinforcement.
Pearl 1, HPV oncoproteins. Remember, E6 degrades P53.
And E7 inactivates ORBI. That's the core molecular hit.
Pearl 2, nodal risk. Keep the rule of 15s handy for quick estimates. Stage 1, 15%, Stage 2, 30%, Stage 3, 45% pelvic node risk.
Useful for initial counseling before the PT scan.
Pearl 3, LACC trial implication. For radical hysterectomy, open surgery is the standard. Minimally invasive is out due to inferior oncologic outcomes.
Non-negotiable takeaway from LACC.
Pearl 4, FIGO 2018. Nodal status now dictates Stage 3C, 3C1 for pelvic nodes, 3C2 for para-aortic nodes. Imaging and pathology are formally integrated.
Huge change reflecting prognostic reality.
And Pearl 5, treatment morbidity from Landoni. The big danger is triple modality therapy, surgery plus adjuvant chemo-T. Aim to avoid it by choosing the right primary therapy up front.
Minimize toxicity while maintaining cure. That's the goal.
All right, let's test application with some board-style questions. Ready?
Let's do it.
Case 1. A 35-year-old woman has stage 1A1 squamous cell carcinoma on her cone biopsy. Margins are negative, but lymphovascular space invasion, LVSI, is present. She strongly desires fertility preservation. What's the most appropriate next step?
Okay, 1A1, negative margins, but LVSI positive, wants fertility.
A, observation only since margins are negative. B, repeat comedization or a simple trachelectomy with negative margins, plus pelvic sentinel lymph node, SLN mapping. C, radical abdominal trachelectomy and full pelvic lymph node dissection. D, definitive chemoradiation.
Because LVSI is the key here.
Yeah.
Even with 1A1, LVSI raises the nodal risk above that minimal threshold. So observation A is insufficient. Nodal assessment is needed.
Right.
Definitive chemoradiation D would work, but sacrifices fertility unnecessarily at this early stage. Radical trachelectomy with full dissection C might be overtreatment for 1A1 plus the morbidity of the full dissection. The modern standard balancing oncologic safety and fertility preservation is B. A conservative local procedure, repeat cone, or simple trachelectomy to ensure clear margins, combined with sentinel node mapping to accurately assess nodal status with minimal morbidity.
Exactly. B is the answer. Nodal evaluation required due to LVSI, SLN preferred for fertility sparing.
Makes sense. Next case.
Case 2. A 48-year-old woman has a 1.5 centimeter tumor. Biopsy shows adenocarcinoma. Staging workup, MRI, PDCCT, is negative. So she's stage 1B1 adenocarcinoma. She's considering surgery. How should you counsel her regarding the surgical approach?
Okay, 1B1 adeno wants surgery. Counseling on approach open versus MIS.
A, robotic surgery is preferred because recovery is faster. B, laparoscopic surgery offers outcomes equivalent to open surgery for this size. C, We do not recommend minimally invasive surgery, robotic or laparoscopic, as the LACC trial showed it leads to higher recurrence risk and worse survival compared to an open operation. D. Minimally invasive surgery is acceptable because her tumor is small, less than 2 centimeters.
This is a direct application of the LACC trial.
It is.
LACC showed inferior oncologic outcomes for MIS radical hysterectomy compared to open, specifically for stage 1A1 with LVSI 1A2 and 1B1. Tumor size, D, doesn't negate the LACC findings for 1B1. Faster recovery, A, is irrelevant if survival is worse. Equivalence, B, was disproven by LACC.
So the answer has to be
C. You must counsel her that based on the highest level evidence, the open approach is the standard of care for radical hysterectomy due to superior cancer control. MIS is not recommended.
correct. Answer is C, direct LACC implication. One more.
Yep.
Case 3. According to the Landoni trial, comparing radical hysterectomy versus definitive radiation for early-stage cervical cancer, stage 1B to 2A, which of the following statements is true?
Okay. Landoni trial interpretation. Surgery versus RT for early stage.
Surgery offers a superior overall survival benefit. B, radiation offers a superior overall survival benefit. C, both treatments have equivalent survival, but severe long-term morbidity is highest after primary radiation. D, both treatments have equivalent survival, but morbidity is highest in patients who require adjuvant radiation after surgery.
All right. Landoni's main findings, survival was equivalent. So A and B are out.
Right. Survival was 83%, Evries 83%.
Now, morbidity. Landoni showed higher severe morbidity in the surgery arm, 28%, compared to the radiation arm, 12%. So C, which says morbidity is highest with primary radiation, is incorrect.
Leaving.
D, equivalent survival, but the higher morbidity in the surgical arm was driven specifically by that large group, 64%, who needed adjuvant radiation after surgery, leading to triple modality toxicity.
Perfect. D is the correct interpretation of Landoni's key message.
Excellent. Those cases really tie the evidence together.
Absolutely. So we've really built the essential framework today for tackling early-stage cervical cancer, using Mrs. Garcia as our anchor.
Yeah, we started right down at the molecular level, HPV, E6, E7, and moved through the epidemiology, the crucial workup with MRI and PTCT.
Mastered the FIGO 2018 staging system, especially that game-changing stage 3C for nodal disease.
And then critically applied the evidence from Landoni and LACC to guide that fundamental treatment decision between primary surgery and primary definitive radiation.
Remembering that while both can cure, the choice often hinges on predicting and minimizing treatment-related morbidity, especially avoiding that triple modality path whenever possible.
For patients like Mrs. Garcia with stage 1B2, where the risk of needing adjuvant therapy after surgery is substantial, definitive chemoradiation often emerges as the preferred approach to maximize both cure and quality of life.
It's a complex decision, requires careful discussion, but understanding this evidence is key.
Couldn't agree more.
Ready to test your knowledge further? Complete practice oral boards and access more comprehensive tutoring resources over at RadOncSmartLearn.com.
And be sure to subscribe to Rad Onc Smart Review so you don't miss our next session, where we'll tackle locally advanced and recurrent cervical cancer.
Thanks for tuning in.